All right, here we go. On to part B of the urinary series. So first case, we've got axial and coronal views centered on the kidney, specifically the renal artery, and we've got the classic beating appearance of fibromuscular dysplasia. This is pretty straightforward, Aunt Minnie. Now let's look at a treatment, this versus that. So on one side we have our FMD case, and on the other side we've got what looks like atherosclerotic calcification involving the ostium of the left kidney, renal artery. So how do you treat these things? So generally speaking, you got two tools, angioplasty and then angioplasty plus stenting. So this is sort of a classic question. FMD tends to do better with angioplasty alone. Angioplasty and stenting are sort of required for the atherosclerotic calcification. And the way that I remember that is FMD is it's predisposed to dissections. So if you think about like dropping a stent in addition to angioplasty, maybe you're going to end up with dissection. That's only sort of part of the story, but that's just the way that I remember it. And, that you need a stent to sort of bridge open that thick calcification there when you're dealing with atherosclerotic disease. So let's talk about renal artery stenosis as something that, when is it real, when is it functional, when is it actually causing hypertension? Because that's when you care about it, right, is when you're getting hypertensive disease or it's damaging the kidney and you're getting end organ failure kind of stuff. So obviously you're going to treat them no matter what if you're a cardiologist, and you're probably going to treat them no matter what if you're a interventional radiologist out in the real world. But for the circus that is academics, let's talk about when you might decide to treat and when you might decide not to treat based on findings, intraprocedural findings. So the thing that you will do by the book, some people advocate for by the book, is you measure a pressure gradient across the lesion. And if you've got a real pressure gradient, then you can say that this is causing a hemodynamic dysfunction and therefore it needs to be treated. So when is a gradient a real gradient? So there's two ways to answer that. One is to say 10 above the mean systolic pressure, comparing the renal artery to the aorta. The other one is to say 20 over the peak systolic pressure. So very important here, guys. Pay attention. If I was writing a test, I for sure would swap these as distractors with these numbers. So when you memorize that number, you got to memorize it as mean. And when you memorize 20, you got to memorize that as peak. And the way that I keep them straight is that 20's higher, therefore it's peak. And 10's smaller, therefore it's average, it's the mean. But you have to keep those straight. Now what about when you're using ultrasound, just pure ultrasound? Is there a way to do that? Of course there is. Probably have read 20 million billion of these things. A ratio of a renal artery and the aorta peak systolic velocity, not mean. Peak. If you get 3.5 or more, then you've got at least 60%. So several different ways here where this language can result in significant trickery, okay? A distractor might be mean instead of peak. Another distractor might be something playing on the words of the fact that this is at least 60%. So it could be greater than 60%, it could be 70% at greater than 3.5. So at least 60%. Okay, so you've seen me ask this kind of question in other modules, and it's almost always a nuclear medicine exam. So can you think of a nuclear medicine test that you could use to evaluate for renal artery stenosis, or whether or not that's actually functional? Yeah, captopril renogram is the answer. So let's talk about that. Okay, so let's talk about some of this, how some of these renal studies are performed, what the tracers are, etc. Some testable trivia with regard to nuclear medicine here. So you've got two main agents, and they're going to do what a lot of nuclear medicine stuff does, or pretty much all of nuclear medicine stuff does, which is mimic normal physiology. So the first one is DTPA, and DTPA is filtered. So this gives you a good bearing on GFR, and I like to think about this as sort of an agent for flow, or it's more like an uptake flow agent. Now, the other one is MAG3, and MAG3 is secreted, so it's not GFR, and we'll talk about why that's important here in a few minutes. Imaging is done in a posterior plane, and the reason that it's done in the posterior plane is that the kidneys are posterior, and you want them as close to the camera as you can get them. Now, exceptions make great multiple choice test questions. So exceptions to the rule would be a transplant kidney or horseshoe kidney when they're anterior. So you still want them close to the camera, so you would image anterior. So a few more points on this. Remember that when you're looking at native anatomy, it's posterior like I mentioned. So it's not going to flip like it would if you were looking at a coronal CT, where you have like the radiologist right and the radiologist left, where it's their right kidneys on their left side and their left kidneys on the right side. You have to remember that it's not flipped because it's imaged posterior. So it would be really easy to screw up if they wanted to know if the right kidney or the left kidney was abnormal, and you were looking at that not remembering that it was posterior. So don't forget that. So here is a way that I keep MAG3 and DTPA straight. I remember one, and then the other one is the other one. And the one that I remember is MAG3. And I think about the number 3, and then I sort of, in my mind, because I'm a visual person, I twist the thing until it looks like an S. So the 3, I just give it a turn, like it's a pretzel or a Twizzler or something, until it becomes an S. And then I remember that the 3 is an S, so 3 is for secreted. And then the other one is the other one. So let's look at what this test normally looks like. Typically you've got, let's go back to this. I'll show you real fast. Remember this? So on the top, you've got this graph, and then down below, you've got pictures that were used to generate the graph. And then over here, it's where the tech drew the regions of interest to do the calculations. So if they didn't circle the kidney correctly, or they also circle something for background, which is this up here. If they didn't circle that, if the background thing was taken on part of the kidney or something, there's lots of different ways that they can screw up drawing the region of interest, which in turn screws up your graft. So it's safer actually when you're interpreting these things to just look at the pictures and then see if the graft makes sense. If the pictures and the graph don't make sense, it's because the technologist typically does this. They didn't draw the graft right. So when that happens, you have to go back and smack them around. So we talked about this stuff. All right, so back here we go. So you do the test twice, once before you give the captopril and then once afterwards. And what you're looking for is for things to get worse. So this is a normal. This is what normal looks like. So orange and yellow are for the different kidneys, right and left. And then here's our image. Remember, imaged posteriorly. So in that case, this would be the right kidney and this would be the left kidney. So it starts out with all the tracer has been normal uptake into the kidneys, and then over time they secrete and the bladder starts to fill up and the kidneys become more photopenic. And then you give captopril, and in a normal person it's going to look the same. It's not going to change. So let's look at two diseased kidneys that have renal artery stenosis with two different tracers. First with MAG3, which remember the 3 is for the S, and the S means it's secreted. So I labeled them here so we can tell which one's which, orange and yellow. And notice that uptake of both of them is pretty normal. It's a little bit less on the yellow kidney, but they're pretty similar. And then we look at post-captopril, and remember what we're looking for here is a difference, but the other way to get tricked on this is to tell, well, which kidney's the bad one, and which one's the healthy one, and which one's the bad one, because it's always going to be unilateral. They have to show it unilateral, and it typically is unilateral in the real world too. So notice that the orange kidney took the tracer up, but it didn't secrete it. All the yellow kidney is emptying normally, but the orange kidney is not. So it's a failure to secrete the tracer. Remember, MAG3 is for secreting. So it has sort of a curve that is persistent, and that's the sick kidney, not the other one. Now let's look at DTPA, or again, we've got two curves here that are fairly similar. And then on the post-captopril imaging, we've got the orange kidney is having trouble taking the tracer up to start with. The yellow kidney is taking it up normally, so that's more of a flow kind of thing, a GFR thing. So that's different. So instead of persisting high, it's not ever peaking to begin with. So that's your sick kidney. You can see the difference there. All right, so just to summarize, MAG3, it's going to be able to take the contrast or the tracer agent up, but it's not going to be able to secrete it because MAG3 is for secreting. And with DTPA, it can't get it up. You want to see it worsen with the captopril to call it positive. So like I mentioned before, you're looking for a unilateral finding with sort of the other kidney you can think about as your control. If they're on an ACE inhibitor, you have to stop it 3 to 5 days prior to the exam. And if you remember from your internship, if you were forced to do one, which probably most everybody was, those are the drugs that end in the suffix pril. So lisinopril, enalapril. The prils are your ACE inhibitors. And the patient should be NPO before the exam. Okay, so the next one is this. Could he have hypertension? So what are we being shown here? This looks like a spine case with a fluid collection coming out of the spine. So when you see that, that is a lateral meningocele. And when you say lateral meningocele, the next thing you should say is NF1. So I say lateral meningocele, you say NF1. And the point of this case is that NF1 patients have renal artery stenosis, or they can. It's actually the most common vascular abnormality associated with NF1. Let's go and do a little bit more nukes here. Let's now talk about transplants. So we've got here is a MAG3, and we've got flow and renogram phases on 2 different patients. So just to sort of quickly show this exam when we're dealing with transplant, just like, well, this is a little different. So we have a flow phase where we can, and that's this part here. And as you can see, you start to see the aorta, and then the iliacs, and then you start to see your transplant kidney picking up the contrast, and this would be normal. And then the second part is a renogram phase, and this is where you want to see the kidney make urine. You saw it had the ability to pull out of the blood. That's the flow phase. Now you want to see it make urine. And you want to see the kidney get progressively lighter, and then the bladder get progressively darker, and it's not happening here, so this side is abnormal. So we'll get back to that in a second. Let's just sort of review what normal would be like. So like I mentioned before, we've got 2 parts to the test. A flow part where you should start to see the vessel, and these are each time points at time point 1, time point 2, time point 3, time point 4. You're seeing the blood flow, and then the kidneys start to take the tracer up, get progressively darker. And then the second part is this renogram phase, where you have a dark kidney, and then you should see it become progressively lighter and the bladder get progressively darker. So here is case 1, where we have our flow phase, which looks pretty normal and getting progressively darker. But in our renogram phase, we just take the contrast and hold it, and we don't ever make any urine. So normal flow, abnormal delayed or renogram phase. And this can be 2 things depending on the time period. It can either be ATN early or drug toxicity late. Now, here's a second case where we have sort of delayed uptake. It's not getting as dark as you'd like to see it get. So flow is abnormal. And then on the renogram phase, it's also not letting go of the tracer, so that's abnormal too. So double abnormal is an acute rejection. And that's the main reason we do this test, is to distinguish between ATN and acute rejection. Drug toxicity is typically done in a different time period. It's late, so it's not a clinical dilemma as to whether or not it's drug toxicity. But for the purpose of multiple choice, that's worth understanding. And the difference between ATN and acute rejection is with that perfusion phase. So ATN will have a normal perfusion, and acute rejection will not. And I just think about the resistance of the kidney being so high with acute rejection that it can't even take up the tracer. So what about fluid collections? There's 2 fluid collections that are sort of traditionally associated with transplants. One is the urinoma, and one is the lymphocele. And there's 2 big differences here that are worth knowing. One is that the urinoma is typically seen early. If you've got a urine leak, that's going to present early. Lymphatic problems will come in later. That's sort of intuitive. And then the second part, worth understanding, which is also very intuitive, is that a urinoma will have tracer in it, because you're taking up a urine tracer. That's the reason the bladder gets darker over time. So you're going to have like a fluid collection around the kidney that has tracer in it, whereas a lymphocele is going to be photopenic, won't have the tracer in it. So that's going to be the end of part B, and we'll move on to the next lecture, where we'll do some congenital abnormalities of the urinary tract and associated GYN malformations, and then cancer of the ureters, bladder, and urethra.